Hi, thank you all for inviting me to come and speak about preoperative antiplatelet therapy for urologic surgical patients. Sorry I couldn't make it in person, but I have a few slides to share on this topic. We're dealing with a multitude of agents when we talk about antiplatelet therapy, but the agent that is really of most concern to us is aspirin. For patients who are on clopidogrel, the powerful indications for continuing this drug in the 12 months after placement of a drug-eluting stent basically mean that there's little debate on whether or not we should use the drug, and in most instances this will lead to delaying elective surgery until that 12-month interlude has elapsed. So the question essentially becomes, how do we manage patients who are on aspirin for secondary prevention of either coronary or cerebrovascular disease? That is, patients who have established disease, they've had a stroke or they've had an MI with or without percutaneous intervention and stenting. They've been, in the case of a drug-eluting stent, through the 12-month window of dual antiplatelet therapy where they would receive both aspirin and clopidogrel, and now they're on aspirin monotherapy and they present for urgent or elective urologic surgery. How should we manage their aspirin in the perioperative period? For many years we didn't have prospective data to guide us in addressing this question. What we did have was large-scale reviews of tens of thousands of patients who had been on aspirin for a secondary prevention indication and who had then discontinued aspirin, as shown in this table here, for a variety of reasons. The most common reason for untimely discontinuation of aspirin in the secondary prevention setting, unsurprisingly to us, turns out to be surgery. As you see here, most of the patients who discontinued aspirin in this meta-analysis of over 40,000 patients were patients who were to undergo surgery. And the finding that is of interest to us is that many of them, or at least relatively many on an absolute basis, went on to experience cerebrovascular or acute coronary or peripheral ischemic events. So there's at least the suggestion that discontinuing aspirin in the perioperative setting is a risk to these patients, and leading the authors of this meta-analysis to conclude that aspirin should only be discontinued perioperatively if the known or assumed bleeding risk and their sequelae are expected to be similar or more severe to those of the observed cardiovascular risks. Well, this leaves us in a sort of difficult spot, and various algorithms have been proposed on how we should manage that. I'll leave the right side of this slide alone for the moment. It basically deals with how should we manage dual antiplatelet therapy patients, and these are almost always patients who've had a stent in the last 12 months, and there are fairly defined pathways for dealing with this patient population. Of more interest to us is the left-hand side of the slide, where we're looking at patients who are using aspirin for primary or secondary prevention. And the primary prevention patients are fairly easy to deal with. These should essentially discontinue their aspirin. But what about secondary prevention? And here, various authors have asked us, including the authors here, have asked us to adjudicate whether the patient is at high or relatively lower risk for perioperative bleeding events on a surgical risk basis, and to decide whether or not to discontinue aspirin based on that risk of surgical bleeding. So where do various surgical procedures fall out in this rubric? It's clear that intracranial neurosurgery and most neuraxial surgeries are at the higher end of the spectrum. but most of the surgeries that we deal with on a day-to-day basis are somewhere in this great middle intermediate catchment area that's difficult to distinguish or resolve where exactly our particular procedure falls in this continuum. Well, specific to urologic procedures, Dave Aronson pointed me to this excellent review article by your professional society that integrates some 2,000 papers and abstracts on the subject of antiplatelet and anticoagulant therapy in urologic surgical patients, and asked very pertinent questions of interest to us all. In whom can we stop antiplatelet therapy? In whom can we continue antiplatelet therapy? And are there any peri-procedural strategies, perioperative strategies that we can use to balance the risks and benefits of prophylaxis versus bleeding? In the realm of anticoagulant therapy, as you know, we have many good strategies for perioperative bridging. Unfortunately, at this time, with regard to antiplatelet therapies, we don't have good bridging strategies, since most of our antiplatelet meds, with a few exceptions, are irreversible inhibitors, and those that are not are cumbersome to use or are intravenous agents. So their recommendations reflect our state of thinking on this matter up until a couple weeks ago, namely that patients should generally continue aspirin, particularly if it's secondary prevention of cerebrovascular disease. We should continue that, and delineated in item number 2 here. We should certainly not discontinue dual antiplatelet therapy if we can avoid it within 12 months of placement of a drug-eluting stent, 3 months for a bare metal stent. At the bottom of the second paragraph, there's some mention of, at the end of that 12-month period, that we should discontinue clopidogrel as we typically do, and then, if possible, continue aspirin if the bleeding risks are acceptable, which again begs the question of when are the bleeding risks acceptable based on the nature of the surgical procedure. There's some more specific language revolving around transurethral resection of the prostate, and I would, if this is of interest to you, there's some very detailed reading in the article itself about various techniques of TURP and laser TURP and so forth, and at least the appearance that these bleeding risks are mitigated with many of the more modern techniques, but please do reference that article if that's of further interest. The item number 17 further assesses nominally higher risk procedures such as radical prostatectomy and partial nephrectomy, and here there's no firm recommendation one way or the other, rather multidisciplinary planning to coordinate antiplatelet therapy is advised. So there's at least recognition that in some of these procedures the bleeding risk may outweigh the prophylactic benefit of continuing aspirin. And finally, there's a general consensus that clinically significant bleeding is not increased by continuation of aspirin for most urologic procedures, possibly excluding TURP. Well, all of this basically summed up our thinking on perioperative antiplatelet meds up until 2 weeks ago, when in New England Journal Medicine the results of the POISE 2 trial were published, and there's a fairly monumental study of close to 10,000 patients who generally had a history of vascular or coronary artery or cerebrovascular disease, who many of whom had undergone percutaneous intervention or coronary artery bypass grafting in the past, and then were going on to have elective orthopedic or general urologic procedures. And when the 30-day outcome of major adverse cardiac outcomes or death was examined, there was essentially no difference between patients who had stopped or continued aspirin in the perioperative period. There was also another group of patients who had been started on aspirin de novo versus placebo, and in those patients as well, the so-called initiation stratum, sort of on the third line at the top, also there was no difference in the 30-day outcome of major adverse cardiac events or death. So this seemingly undermined much of our thinking on perioperative antiplatelet therapy by suggesting that there really was no clinical benefit to continuing aspirin in the perioperative period in most patients, while on the other hand there was an increase in the incidence of clinically significant bleeding, nominal absolute increase in risk of 1 to 1.2% in the early perioperative period, the first 2 to 3 days after surgery. So this really threw into doubt much of our thinking on perioperative antiplatelet therapy, which seemed fairly clear-cut up until 2 weeks ago. I think at this point it's back to the drawing board for perioperative antiplatelet therapy, in particular patients who are on aspirin for secondary prevention. We need to rethink our approach and whether it makes sense to continue aspirin in the perioperative period. This may not be the ideal approach for many of these patients. I will mention that in the POISE 2 study, patients who had been on aspirin for secondary prevention discontinued aspirin at 72 hours before surgery. So this is a little bit shorter window than we would typically use. We would usually ask patients to stop aspirin 7 to 10 days before surgery. These investigators felt that, and the clinical data bore out, that a shorter window was acceptable with recovery of about 12% of platelet activity per day after cessation of aspirin therapy. 72 hours seemed to allow for adequate recovery of thromboxane activity at the platelet level. So at this point, perioperative medicine clinic has no definite or suggestions to make on the topic. We're going to have to reassess how we think about antiplatelet therapy in our surgical patients, and it may be that we are going to shift our bias towards discontinuing aspirin in most patients in the perioperative period. Certainly patients who are beyond the 12-month window after placement of a drug-eluting stent and are on aspirin for secondary prevention. The available evidence now suggests that we could consider discontinuing aspirin in many of these patients who are undergoing surgical procedures with a higher risk of bleeding. I'll leave it there for now.